and then people can just unmute themselves as they're going to talk.
Got it.
So I am letting folks in, and then I'm going to share screen so that you have the presentation up. Not coming up for me. No, can't be that one. Hold on. Sorry, everybody. I know I have it here. Can you guys see my screen?
It says CPAC has started screen share. There it is. Ta-da.
Perfect. And you let me know when you are ready so I can present you, and we should be good.
Yeah, I'm all set whenever you are.
So thank you everyone for joining us. I have Dr. Marybeth Ellison, and she's going to be presenting for us. Dr. Marybeth, would you like to introduce yourself?
Sure. I'm Marybeth Ellison. I do developmental and behavioral pediatrics, and I've done that for a couple of decades. I helped train the residents at Yale and the fellows, and what I'm most interested in is capacity building into the next generation of physicians and people that work with kids with ADHD, because I'm very passionate about the phrase of neurodiversity and how can we help everybody move these kids forward with sort of a better understanding, because knowledge is really power.
Thank you. And I'll turn.
So you want me to just go, Kia?
Yes.
Okay, awesome. So ADHD really is the most common neurodevelopmental disorder. And I think like lots of things under the mental health umbrella, people are like, well, snap out of it, or it's just poor choices, or it's just, they don't believe it's a quote unquote real diagnosis, which is pretty interesting, because it certainly is, as much as depression is. And I think it's a fascinating time to be in neuroscience, because we can actually see the underlying differences. And so the first thing, I want to reiterate is that it's real and it's common, and we can see those differences, and the differences that we see in brain neurobiology is what leads to the differences in behaviors and some of the problems that we see. But it also is empowering, because we can see ways that we can actually help move these kids forward. So it really is the most common. 8 to 9% of children, boys, are still more affected than girls. It's interesting because we wonder if in fact girls are underdiagnosed, because they're more likely to have the inattentive type. But even when we control for that, there is a definite preponderance of boys versus girls. It's also one of those things that's sort of international, which is sort of fascinating. So it really, in different countries, is different populations. And is it a matter of a different threshold for acceptability of behavior or that sort of thing? But it's, I always am reminded of one of my patients whose last name is Wigglesbottom. And the dad said, oh, everybody in my family has had ADHD for as long as anyone can remember. And you can picture in like Old English when they talk about, the last name of Baker, or the last name of whatever their profession is. And this family's last name was Wigglesbottom. So sort of cute. Because it is a neurodevelopmental disorder, with enough time, a lot of the kids will outgrow a lot of the features. So meaning that as the brain myelinates, we'll talk about some of the differences in a minute, but as the brain changes and as they mature, they literally will outgrow lots of features. And even for the features they don't outgrow necessarily, they also can develop coping strategies and things like that. So about 30% truly persist into adulthood, in terms of if you were doing functional MRIs and brain scans, you could see that there was still a difference of a less connectivity with the prefrontal cortex, but in 2/3, they literally outgrow it. But that's not going to happen until mid-20s. There's a big overlap with other neurodevelopmental disorders as well, because we know that it's more common and more frequent if kids have language disorders, if kids have features of things like an autism spectrum. And that's not talking necessarily about the comorbid disorders, which we'll get into, and that's certainly includes lots of learning disabilities, anxiety, depression, oppositional defiant disorder, and other things like that. But ADHD actually co-migrates. So it is a much higher incidence if you have seizure disorders, for example. It's much more likely that you have ADHD. I wasn't sure if that was a question. Okay, let's go. So it is a neurodevelopmental disorder with a biological basis. So it's highly heritable, meaning that there are a plethora of genes involved. It's not a single gene inheritance pattern, but there are lots of genes involved, and there is absolutely a strong genetic component. And that's been borne out by lots of different types of studies, more highly heritable than other things that we think of as really heritable, like schizophrenia, depression, anxiety. ADHD is even more conserved and likely to be passed on to the generation. And I try to remind the resident physicians I work with when a mother calls at 9 o'clock on a Sunday night because they ran out of medications, that she may in fact have ADHD and she forgot to look the previous week that they were running low on medication or whatever, because it does tend to run in families. And most of the genes that are involved logically make sense of the neurotransmitters and dopamine and those sorts of things, which are the targets of some of our therapy. So although there's a genetic basis, you can see in red at the bottom, there are also environmental factors and epigenetic changes that make it more likely that these will be seen, and may be seen to a greater degree of affect or symptoms in subsequent generations. So some things that have been associated with it are lots of different things in utero. So maternal smoking, alcohol use, premature birth, and very low birth weight. Infants less than 1,500 grams have a much higher incidence of having ADHD. Head injuries is really interesting, as post-traumatic brain injuries, but even concussions, because when you shake the brain does not like to be shaken. And when you shake it, you disrupt those, what we call white matter tracks. And those are the ones that let us think before we act. And those are the ones that give us sort of that executive functioning, the big picture of being able to organize things. And those get really disrupted even from concussions. So it's interesting that sometimes symptomatically we can treat those kids as well. Infections during pregnancy and at birth are increased to risk of ADHD, lots of different things. And then a slew of environmental toxins. Everyone's familiar with lead and its effect on cognition. It also has been shown to be associated with ADHD, but then lots of things, unfortunately, in our developed world. And so it's one of my areas of personal interest, but I won't bore everyone, but there's things called epigenomic changes, meaning your genes get passed down from generation to generation. But there are things that are toxins in our environment, and whether it's PCBs or chemicals in whether lawn pesticides or fracking, whatever they're used for, they take a long time to break down, and they have the ability to sit on our genome. And so when a gene is getting replicated, it doesn't replicate correctly, and those are called epigenomic changes. And so that is probably one of the leading reasons that we're seeing increase throughout societies in industrialized civilizations of things like ADHD and autism and other neurodevelopmental disabilities, because these things all now become part of our genome, which is pretty terrifying. Okay, so this is a simple schematic of just sort of the pathways that we're going to be talking about. So when it comes to ADHD, dopamine, the blue one, is the one that's really sort of running the show. So everyone's heard of a dopamine rush, everyone's heard of the amygdala detour, things like that. But so when we look at the prefrontal cortex, that's where you're making those decisions, and you have 8 major pathways of dopamine. We wanted to affect these so you can put the brakes on before you act, and so you can direct your attention. But it's also fascinating, if you look at the functions down here, it's related to motivation and reward and pleasure and all that sort of thing. So for some of these kids, it can be possibly less fun to learn, right? It's not really motivating to write your spelling words 5 times or things like that. So when people from the outside look at a child and say, well, they're just being lazy, I'm not sure they're being lazy, as they need to sort of readjust how they're thinking about it. Yeah, Mikia, you're in charge of my slides, lady.
Sorry. So you're done with this one? I'm sorry.
Yep. So dopamine, we'll talk about the medicines that work on this. So this is a really important slide to me. So there are lots of different brain differences in lots of different studies. So there's more asymmetry or unevenness of your cerebral hemisphere. There is somewhat smaller on the left-sided prefrontal cortex. Those are different in blood flow and cerebral vascular volumes. They're overall a little bit smaller if you have ADHD. The myelination maturation patterns were the first things we noticed. So myelin sits over the top of your brain like insulation in your attic. And the patterns and the thickness of the myelin are about 18 to 24 months behind neurotypical peers. So when you say that kid's more immature, that kid is literally more immature. Their brain is less mature, and they have, with enough time, that will come in. But again, no one ever looks at a 23-year-old and says, you're so immature, you're acting like a 21-and-a-half-year-old. But they say it all the time to a 6-year-old, you're acting like a 4-year-old. And so you can see that it makes a pretty big difference. Another big difference, the fourth from bottom, is weaker, more immature frontal striatal tract. So on the previous slide, you could see how the dopamine in your prefrontal cortex works and relates down to the deeper parts of your brain, your emotional centers and things like that. And those connections, when we look at brain scans, are like highways in kids that don't have ADHD, but they're like dirt country roads in people who do. So it's just much harder for them to put the brakes on. And those differences are really clear on a myriad types of biological scans. So I like the next picture. So with less dopamine, if it's related not only to your attention, but if dopamine is also related to your motivation center and things like that, there is less dopaminergic activity when we look at different types of positive emission tomography scans throughout the brain. So kids with ADHD actually make less of this in that area. And it's postulated probably pretty accurately that it's actually less fun for them. They are less motivated. And when I'm in a room full of real people, I say, raise your hand if you sat in the car and listened to the end of an NPR story that was just fascinating, or the end of a TED Talk, or something that was really interesting. But for a lot of these kids, it's not as much fun to learn. So you can show the scan, Kia. So control subject on the left, you can see how much dopamine uptake they have in this area naturally. And this is an ADHD subject. They have less, it lights up less. It's literally when you say things light you up or make you interested or light up your brain, it actually is, it's less in these kids, unfortunately. So when we talk about assessment, there is a gold standard of assessment, and sort of everybody, but no matter what the initial alphabet soup is, whether it's the Academy of Pediatrics or Child Psychiatry or National Institute of Mental Health, for all of you that read the Rats of Nim at some point, which was a really cute children's book. So it's all pretty similar. And so we want to look at things in more than one setting, and there's a set of criteria, but although brain scans are fascinating, that's not part of the diagnostic process at this time, and probably won't be because of the prohibitive cost. So the criteria are, and when we look at it, I think of ADHD, and some people still say, well, what about, I think I have ADD, I don't have ADHD. It's all ADHD. So there's ADHD predominantly inattentive type, which means it doesn't have the hyperactivity, but that's just the name. Don't blame me. And then there's ADHD predominantly hyperactive impulsive type, which is actually the least common. And then there's ADHD combined. But on those, you need to meet a series of criteria. So when you look at these, if anyone is involved in education or anyone's worked with a child at home trying to do homework, you can see that these symptoms, and you have to have at least 6 out of these, they have to be present for at least 6 months to the point that it's impairing function. So that's one of the important diagnostic criteria. So we all can be a little bit anxious. We all are probably a little bit anxious because of the COVID, but does it impair our functioning? So for attention, it's sort of the same thing. And so does not give close attention to details, making careless mistakes, trouble sustaining attention on tasks. The play activity is more for little kids, but and video games are all bets are off because it's visual and moving, and kids with ADHD tend to be, their brain is wired, it has a propensity to be visually stimulated as opposed to auditorily. And so when something's visual and moving, they lock right on. But sustaining attention to a non-preferred task, that's much harder for them. Often doesn't seem to listen when spoken to directly, doesn't follow instructions or fail to finish schoolworks, trouble organizing activities, avoiding or dislike not wanting to initiate schoolwork and things like that. That is a big issue, and the people down at Johns Hopkins think, I want to rename it attention initiation, like it's a problem for them to start things as much as anything else. Often loses things needed for tasks. Those are, again, part of the executive functioning, keeping track of everything. Is easily distracted or often forgetful in daily activities. And again, these happen to all of us once in a while. We've all read a page and gotten to the bottom of it and said, what did I just read? And you have to go back and reread it because you were distracted because grandma's in the hospital or your baby's crying or something. But if that happened to you every time you read a page, that would get pretty old. This for the hyperactivity impulsivity one, again, you need 6 out of these to qualify for that. Fidgets with hands, squirms in seats, gets up from their seat when sitting is expected, runs about or climb where it's not appropriate, or for older teenagers, just feel a little internal restlessness, trouble playing or enjoying things quietly, often is sort of on the go, driven by a motor, talks excessively, blurts out answers before questions have even been finished, trouble waiting their turn. That's a big one that teachers see often in elementary school. They always want to be first in line and they don't want to wait for their turn to get back to be first in line again, and often interrupts or intrudes on others. So this is sort of just the check work of making sure it's not something else. So previously impairment had to be, this was a big change in the last DSM-5. Previously, those symptoms had to be present before age 7. Now they can be present before age 12. So we actually can capture more kids in the diagnostic umbrella because we realize that some kids don't present until more like 7, 8, 9, when they are required to sit longer for school and engage more, especially kids that are bright because previously they may have compensated. It has to be in 2 or 1 settings. So criteria C, super important. So which is why all the teachers, and if there's teachers out there, why we need to get you involved and professionals from the school setting, because kids do act differently in different settings, and behavior is a communication. But for a lot of these kids where it is difficult for them to control these things because it's biological, we'll see it in more than 1 setting. So it has to be present in more than 1. Clear evidence of impairing the functioning again. So if you have it, but it's not really causing a problem for that child, that it doesn't really get diagnosed. I would argue, based on now what we know about neurobiology, that can be a little outdated, because for a child who has ADHD to pay attention, to sustain attention, even if their behavior looks good from the outside, they are probably working so much harder. And in fact, we can see that sometimes on different types of PET scans. They're using so much more oxygen and they're using so much more glucose, sugar in their blood, to be able to try to pay attention, that it's actually costing them more. So even though they may not be bothering anybody else, they're spending a lot of energy. So when I read this one, I always cringe. Evidence of significant impairment. How much impairment is considered significant and by whom? And if they're not bothering anybody else, are we going to pick up on that? And then of course that it's not a more significant diagnosis like schizophrenia, et cetera. So using those, that sort of repeat. Let's go on to the next one. Yeah. So looking at, so from a physician's point of view, we obviously want to rule out, can they see? Can they hear? Is there anything going on that's medically problematic for these kids? It's incredibly interesting because 20% of children in one sort of big meta-analysis study found that kids who had difficulty with attention the next day didn't get a good night's sleep. So I always talk about, when we'll talk about treatment in a minute, but we always talk about a triangle, a common sense triangle that you need to pay attention. And that's a good night's sleep, a healthy diet and some protein in the morning, and regular exercise, because all those things help you pay attention because they all help increase your neurotransmitters. But in one big study, 20% of kids actually just had sleep disordered breathing or disrupted sleep that was making them look like it was ADHD. And when that got fixed, either with tonsillectomy and adenoidectomy in the case of obstructive sleep apnea or CPAP or whatever, then their ADHD symptoms vanished, which is pretty interesting. So the benefit of multiple perspectives. So when we try to figure out if someone has ADHD, you sort of need both medical and psychological and education, because it all, especially when we're dealing with younger children, because it really impacts all those things. So we need opinions from all those things. So most common way are the parent interviews, child and parent interviews, the rating scales. So a lot of times physicians will do Vanderbilt because they're in the public domain and they are a little bit shorter. Schools often use BAS-3s or Connor rating scales, and developmental centers use those. They're a little bit more detailed, but they're also more onerous for teachers. And if there's any teachers out there, I know that, the 110 questions of a Connors 3 is sort of exhausting and a lot to expect. And it's specifically difficult when you're in a middle school or a high school setting and you're expecting that from 7 different teachers. So we get that that's a big ask, but we also do think that this is super important, and that still remains sort of the cornerstone, even though we can do other things. And so looking back, a lot of times parents will say, well, I can't get that information from the school, or they just moved here from, California. We don't have any of those records. So even if they have the old report cards, it's really helpful. So things like looking at things like has difficulty following directions, or has difficulty completing work on their own, or bothers their neighbors, or things like that. Then we sort of like, well, clearly there's stuff sort of going on in there. Okay, we'll just move on to the next one, Kia. So again, this overlaps with more of the medical stuff, but what else are we looking for? And is it someone who's got a learning disability and they're not paying attention because things are hard for them? Are they having more difficulty learning because they're not paying attention and it's taking them longer to get to an endpoint? Or is it a combination of both? So there's a whole plethora of testing that can be done either in a developmental clinic or in a school setting, and to sort of figure out who needs and deserves that is also part of the game. Up to 20% of kids diagnosed with ADHD are actually misdiagnosed. They have something else. But what's really interesting is that 2/3 of kids with ADHD will have at least another concomitant diagnosis. And the most common for those are learning disabilities and anxiety or depression. And it's, again, going back to, so ADHD is more common with seizure disorders. So those neurons tend to fire together and wire together. So we see that they co-occur. But with ADHD, sometimes the secondary diagnoses are a result of having ADHD and not having it treated. So if you're a goody two-shoes, want to be an A student and things are harder for you and you have ADHD, you may have anxiety, or if you're not doing well and you sort of want to give up, you may have some signs of depression. So lots of testing. We're back to these, to the BAS and the Vanderbilts and the Connors and things like that. So again, when we think it's affecting a child's learning, or there's other things going on with language or fine motor skills or things like that, then it is important to bring in members from the whole school team, the psychologist, the speech and language, or the OT. When way before I was even in med school, but back in the 70s and early 80s, they called ADHD minimal brain dysfunction. Great name, right? So because it affected their attention, it affected their learning. They often had some subtle speech and language delays, especially receptive language and auditory processing. They often had weaker fine motor skills, but fabulous gross motor skills. They could climb up anything, but they had a harder time writing. So it sort of does affect lots of different facets. So testing that, I don't know if there's any parents out there, but there's lots of different types and they sort of fall into buckets. So developmental, we tend to look at younger skills, developmental levels around social and motor skills, language skills, cognitive, those sorts of things. Cognitive looks at your ability to be able to process and solve problems. So commonly in the past, it used to be called IQ, or intellectual quotient. We recognize there are lots of different ways to be bright, and a number isn't an end-all be-all. We broadly break those into sort of a verbal component and a perceptual reasoning or visual component. And then closely related to that are processing speed and working memory. And that tends to be slower and lower in kids with ADHD. So it doesn't have anything to do with how smart they are. It can co-segregate. So Bill Gates has ADHD, and Michael Phelps with 28 Olympic gold medals, who can be really achieve a ton, have ADHD. But if we do look at cognitive profiles, working memory, which is your ability to hold something in the front part of your brain and the blackboard of your brain and be able to spit it back out like you would do for a pop quiz, that sort of thing, that tends to be a relative weakness in kids with ADHD, which is why they tend to be visual learners and do better with, multiple choice tests and things that they can see. Education looks at their ability at the time. Speech and language, again, looking at auditory processing, because that is a relative weakness in kids with ADHD. OT looking at the fine motor skills, and then psychological behavior looking at mood, coping skills, and functioning across many levels. So most common, we sort of touched on this already about ODD, mood disorders, conduct disorders, those sorts of things. We'll skip that one, Kia. I want to keep it to a reasonable length. Keep going, that one, we talked about that. So how do we make it better for these kids? So we know when we find someone with ADHD, we talk about a triangle of treatment, and I feel like my med students and residents can do this in their sleep, but really a multifaceted approach, those kids have the best outcomes. What do we mean by the best outcomes? We mean staying in school, doing well in school, not being retained in grade, graduating from high school, attending college, not having an alcohol problem, not having substance abuse, not getting arrested as a youth, not getting incarcerated, not getting divorced. I mean, the laundry list of things, the outcome data show that if in fact we identify these kids earlier, and there was a big article that caused a big hullabaloo at the end of August 2019 when they said we really should be identifying these kids earlier, even preschool and kindergarten, and sort of managing them so that we reinforce the right pathways of behavior and learning and that sort of thing, because the earlier we detect these kids and the earlier we bring resources to bear on these kids, the more likely it is that they're going to outgrow it, but the more likely also they're going to feel good about themselves and they're going to want to stay in the academic environment. So they fall into 3 categories. Triangle of treatment, I usually put education at the top of the tree. I must have done this slide after. So looking at the types of plans you can get, whether it's a 504 or an IEP or SRBI for behavior plans, and Kia can even speak more about that. We talk about therapies for younger kids that focuses on parent sort of training and consistency and learning the appropriate paradigms. For older kids, it can be learning emotional regulation skills and things like zones of regulation or super flexible things like that. And behavior modification and therapy is considered the first line for kids less than 5 years of age. And then the third corner is medication. And unfortunately or fortunately, medication really does work. And most of the medication focuses on those dopamine pathways and that we talked about earlier. But kids who have all 3 corners, those have the best outcomes. So for any of you that are in school is critical, obviously. So we can't do this without you guys, and it's sort of super hard because we're busy, you're busy, but talking to teachers is really important. But then trying to get the appropriate supports at school, and for ADHD, you most commonly get a 504 plan if there aren't any true learning issues involved, and that can provide accommodations and modifications. So can sit in the front row, can do every other example on the homework problem, can get up and take motor breaks, can sit on a special kind of wiggle cushion, can have a fidget that they keep at their desk. So the accommodations and modifications don't change what the child is learning or how they are taught, but it makes them, it allows them those accommodations modifications under 504, which is the American with Disability Act. An IEP comes under a different law that comes under IDEA, and that's a much more formal plan, an individual education plan. And that requires either testing sort of a higher level, either by an outside center integrating with the school or by the school team itself, and then going through their checklist and qualifying. IEPs have much more well delineated goals for specific things. And you can't get one under the primary disability OHI ADHD. It's just less common unless there are concomitant speech and language or learning or other issues involved.
Dr. Ellison,
Yes.
Maria Ramos raised her hand. Maria?
Yes. Good morning. Everybody listen to me?
Yes.
Yeah, good morning.
Okay, so my name is Maria Ramos. I live in Bridgeport, Connecticut. So well, my first language is in Spanish, but I like this group for more information, more understanding. But my son has ADHD, diagnosed for kindergarten. Now my son has 17, is senior now. Information for me is awesome, but my question is, this information is possible bring in Spanish for the parent? The maternal language is in Spanish, so for me, understand most better what is the different information. Is awesome information, but it's most easy for me understanding in Spanish. Is possible?
Yeah, that's funny. I'm going to say that's great. And I'm going to turf you right to Kio, who's fluent in both languages.
Maria, yo me comprometo entonces a traducírtelo. So I said to her that I'll translate it.
Thank you so much, Kiomari. Thank you so much for the opportunity to asking.
Absolutely.
Okay, so we touched on this a little bit, and I know that we can go back, but it's being mindful of time. I'm actually going to skip forward, Kia. Let's go to, I keep going. Okay, that one. Whoop. So when it comes to medication, just a word about medications, go back to the previous slide about the stimulant, if you don't mind. So stimulants are considered first line. Everyone hears that word and goes, and people say, I don't want my child to get a narcotic. It's not a narcotic, but it is a stimulant, and they're called stimulants because they stimulate dopamine in your prefrontal cortex. So back to that initial slide back in the beginning when we were talking about the neurotransmitters involved. So what it does is it raises that level up, it leaves it up for a couple hours, and it comes back down again. It said, so the FDA, who has to regulate medications, is different from the NIH, the National Institute of Health, that looks at efficacy and data. So the FDA said this can be habit forming and meaning you could become addictive. And that technically is true. Having said that, there's oodles of research that if in fact you have a legitimate diagnosis of ADHD and you are on and taking regularly a legitimate stimulant medication, you have a lower incidence of having an alcohol abuse problem or substance abuse problems in adolescence or adulthood, because you actually need it, and giving you a low continuous dose makes you less likely to then succumb and self-medicate. So I just really want everyone to know that. And I have no agenda. I'm certainly not pushing medication, but the data says that when you have all three corners, those kids do best. And so I want to empower them to do whatever they want in this big wide world. And the data says that when we treat kids, and we treat kids younger, even starting from elementary school, they do better. So the stimulants can be short acting. Those are the old ones we used to use at 4 hours, and then kids would go to the nurse's office at lunch and get a second one. And for some kids who have difficulty with weight gain and things, we still use those because the longer acting ones last for 9 or 10 hours, and they're often not hungry at lunch and things like that. That's the most common side effect we see. It can also affect sleep and things like that. And we've already talked how important sleep is. So we want to make sure we don't want to throw off that axis. Yep. Also non-stimulant medications, those are sort of different. You have to take them every single day, and they take a couple weeks before they work, but they can also be helpful. Keep going. Some of my farm, keep going. Okay. Yep, it's that one perfect. So there are other things we can do. That's what everyone always asks. Diet has been looked at ad nauseum and has not been shown to be effective unless you have a specific allergy, whatever. So if you have celiac and you need to be gluten-free, go for it. But if the patient has a true allergy, it will be helpful. Otherwise, it won't be helpful. But it makes sense to have, when you can't have healthy food, have some protein for breakfast. Those have been really shown to be helpful, and no one needs to, lots of red and yellow dye and high fructose corn syrup. Omega-3 fatty acids is the one add-in vitamin that has been shown sometimes to be helpful. The studies go back and forth, but that's fish oil vitamins. And most children can have 1,000 milligrams safely if they're over the age of 5. And so that is something that can be helpful. Melatonin, which we make in the center of our brain and our pineal gland and gives us our day-night cycle, that can be helpful for kids who have trouble settling down in the evening, which is pretty common. But all the vitamins are over the counter and they're not FDA regulated. So, so that's sort of interesting. A lot of times people are willing to take lots of things over the counter, but not as willing to take a medication, which may actually be safer because it's been more regulated. So following up these kids, again, we want to stay in touch with schools. We want to know how they're doing. Sometimes we'll ask for a repeat Vanderbilt scale or something to try to say, is the medication working? We always want to have open lines of communication with teachers and things like that. We really think of it as a therapeutic alliance between the family, the educational system, and the prescribers when it comes to that. And we do follow up, even if they're not on medications. We really like to see them every 3 or 4 months. And how can we give them tools and strategies to develop executive functioning and use lists and have reminders, and how can we bring all those tools in to help these kids sort of be their best self?
That was your last slide.
I know, I'm done. I was trying to keep it. You said half an hour. That was 35 minutes, but I talked fast. So that was probably, you know me, I got it in.
So I just want to share with you through Facebook, Heather Plenzio Deerberger, I hope I'm saying that correctly. She says Dr. Ellison is the absolute best. I think you should know that. And then Ellen Johnson Fischel, I believe, says, hi, Dr. Ellison. So I wanted to share that with you.
Thank you.
If anyone is on here and you have questions specific to what Dr. Ellison said, or maybe something else bubble up, feel free to ask now. I don't want anyone to feel like they can't ask questions. I want to make sure if you have a question, you're able to ask.
Yep. And then, Kia, let me just add quickly that the other thing is at the end, you can feel free to share my email address, the marybeth.ellison@yale.edu, because some people might feel more comfortable asking a question just sort of one-on-one, and I have no problem with that whatsoever.
Which one is that one, Marybeth?
Marybeth.ellison@yale.edu.
Okay, thank you.
That's just, I think that's the easiest.
Any questions? No hands are raised. All right, then. Well, thank you for sharing so much.
Thank you.
Yep, you have a question? Please ask.
No, thank you.
Okay.
Oh,
You're
no.
welcome. Thank you,
All right.
Kia.
Absolutely. Have a
Question?
good day, everyone.
Anybody, can you hear me?
Yes, we can hear you, Andrew.
Hi. Thank you very much. This has been very informative. I really appreciate it. My son is 22 years old. He's got ADHD. He's been high dose for a long time, 40 milligrams in the morning and then at noon, and an extra a bumper at 10 milligrams in the afternoon. This is well beyond the normal, the typical prescribed. Is it common that doctors prescribe beyond the standard amount of Focalin? Because
Yeah, it's a great question.
And now that's getting rejected by the new insurance company that we're on, unfortunately.
Yes, right. Yeah, so it's interesting. So there is a phenomena of tolerance. So if I'll use my little hand model. So when the electrical impulse comes down this neuron and releases into the synapse or the gap, and now you have more dopamine that we talked about, and then it gets picked up by this neuron and happens a million times. When you have more around, this neuron gets smarter and tends to grow more receptors and suck it up faster. So that's sort of a phenomenon of a crude interpretation of tolerance, and sometimes why doses have to be chased up. There are some people in the field that feel because of that, sometimes switching back and forth between different types of medications can be helpful. So there are two families of stimulants. There are the methylphenidates, of which Focalin is a member, and then there are the amphetamine-based ones like Vyvanse and that sort of thing. And James Swanson, who's a guru in the field, often does one for a year and then switches back and things like that. I typically, especially because I tend to work with younger kids and get nervous. So yes, we will go above the FDA recommendation in some cases, but when it starts to get too high, then that's, I think, a real important role for the non-stimulant medications. So those medications can be added in. So I sort of breeze through those, but things like Intuniv and Strattera and things like that, non-stimulant medications can be added with stimulants to help them work better. And those are in your system all the time. So sometimes, but rather than chasing up the stimulant, put them on a high dose, and then adding in a non-stimulant can be helpful. And then certainly maximizing all those other corners, different sorts of therapies and different types of exercise, those things. I love giving talks and everyone says, wow, what's that? It makes, attention go up and depression go down and anxiety go down. Yeah. And that's exercising for 45 minutes aerobically 4 times a week.
Dr. Ellison.
That's excellent advice. Yes, thank you.
I have a couple of questions on the chat for you. One is, do you do professional development for teachers? I have a PTA president that would like to do this kind of focus for her group next year. That's Lisa LaBelle's question. And then Amy Christine asks, is there any information on Abtensio?
Yes. So the answer is yes. I believe knowledge is power, and I do that for free whenever I can in terms of helping districts or doing, speech. I've just spoken to groups of like speech and language pathologists and OT and that sort of stuff. So I'm happy to do that. And Abtensio is another methylphenidate. So that is a long acting one. So it sort of came out to sort of replace Concerta, which is an osmotic release one. So that's we have used Abtensio. So the problem is, and I'll go back to my 2 hands, there are only 2 stimulants. It's ridiculous. I mean, considering how many drugs we have for everything, we have methylphenidates and we have amphetamines, and amphetamines just sounds worse, right? So we all, in general, we start with the methylphenidates, but Abtensio is a long acting methylphenidate. And now they've come out with they come out with a couple that you can take the night before and then it releases the next morning, but they are all the same active ingredient. So methylphenidate, which is Ritalin, Focalin, Daytrana patches, Concerta, Abtensio, Quillavent, Quilitu, Metadate, methylphenidate ER, methylphenidate LA. Those are all variations on a theme. So Abtensio is a long-acting methylphenidate. And the only thing that the drug companies are allowed to patent now, because the active ingredient is the same, is the delivery system. So they all say our Cotempla is an orally disintegrating tablet. It goes in more slowly, or, you know what I mean? So they all have their shtick on how their delivery system is the best, but it's the same active ingredient.
Anyone else have questions? Just want to make sure we don't leave with any questions that have been bubbled up. This is your time. Dr. Ellison is here for you.
Good morning, Dr. Ellison. My name is Charlene. I have 3 family members with ADHD, but my question for you today is, my concern is the piece where the depression shows up. And if you have a suggestion on what you feel, besides talk therapy, if there's anything else you feel would be important to address that component that tends to arise with the ADHD component.
Right. So whenever we, again, because comorbids of mood disorders are pretty high, we have to, if someone is in therapy and the talk therapy, sometimes that's really helpful because there are sort of allying and teasing apart. Is the depression secondary to poor performance and things like that? And if we make the school environment better, we fix some pieces of that, will that feel better? Or is the depression its own diagnosis, meaning is it its own separate diagnosis that needs treatment? So for both anxiety and depression, talk therapy helps about 60%, medication helps about 60%, but when you have both talk therapy and medication, they help at about an 80% level. So we know that if things become problematic, then adding in a medication, under the recommendation of a psychiatrist or DBP or someone who works in this field may be indicated.
I want to say on the chat from Sabrina, I have been doing the distance learning thing with my 10-year-old 5th grader. He is not medicated and this has been quite eye-opening for me. He also has dyslexia. I have placed a call to his pediatrician because he is at the point that he is just not functioning. Every task is just so difficult for him, and I see such an internal struggle. We are at the meeting point. He was diagnosed at 3. Any recommendations would be great as far as how to start. I have a sleeping baby, so can't really speak. No worries, okay. We will help you.
Yes, yeah, and I think the whole COVID experience has been really eye-opening for lots of families. And I always say this, and I mean it sincerely. Like I want families to be functional and happy. But when I prescribe medications, it's always to make that child feel more powerful and more capable. Sometimes parents come in and be like, "Oh my gosh, what can you give them?" And it's clearly not you. But I think that it is really difficult. And I think that for them to sustain their effort on a non-preferred task and to keep motorically still and to engage in a positive way is really, really frustrating. It upsets me that kids with ADHD often feel less smart than they are because they feel like, well, things are taking me longer. My other classmates are done, or I can't pay attention to this. I have to read this umpteen times. And they equate it like, well, I must be doing something wrong and I'm not as smart as I am. And so I think that especially for kids who have a double whammy of a learning disability, that was a big Swedish study that came out. So especially if there's learning challenges with reading, medication can actually help them learn faster and read faster because I only have to read it one time and now I've retained it and I can move on to the next thing. And so they feel more capable and more competent. So yeah, so you should talk to your pediatrician if he's already got the established diagnosis, then starting with a low dose. And we always start low and go slow and then titrate up as needed because we'd rather have a child have just a little effect, but no major side effects, most common of which are decreased appetite and trouble getting to sleep.
So Dr. Ellison, I have a mom through Facebook, Virginia Jen Corelli. She wrote, having a lot of pushback from my daughter's SPED team, have annual PPT today and was wondering what I can do to get resources into her IEP without a fight from the SPED team. So we're going to respond as CPAC, but if there's any suggestions that you may have.
Yeah. So if her diagnosis is ADHD, I mean, the other thing I just wanted to speak to too is how you have to try to have as much structure as you can as home, because it's impossible to have your home as structured as school is. But if you can try to sort of set up quiet spaces and noise canceling headphones and a visual schedule for these kids, because their visual strengths are so much stronger than just auditory and telling them. So if they have a visual schedule, they can see and feel more in control. But I think that, you know, it is tricky with different districts. That's one of my complaints, that there's such heterogeneity in Connecticut schools based on what the district is in terms of resources they prescribe. But there is a pretty standard list of things that it can include. And so looking at, I'm sure Kia can give you some of those resources as well, to look at sort of things that can help make him or her feel more capable.
So Virginia's son's is actually dyslexia. She just wrote that. And then Cindy through Facebook wrote, wow, amazing presentation and information. I can feel your passion for helping these kids be their best and feel successful. Cindy, I work with her and she's fantastic. Maria has a question. She raised her hand.
Sí. Kiomari, ¿podrías ayudarme a interpretarla?
So I'm translating. Sí.
Yes. Mi hijo tiene una psiquiatra pediátrica que está especializada en comportamiento.
Uh-huh. Sí.
Y es una de las mejores pediatras de comportamiento que recomiendan en mi ciudad, que es Bridgeport.
Her son has a psychiatrist, and per mom, she's considered to be one of the best in her area, which is Bridgeport.
Pero mi preocupación es que mi hijo, al tener 17 años, él domina los 2 idiomas y la psiquiatra se comunica con él para saber si le va a cambiar la dosis o se la sube o se la baja del medicamento, pero cuando ella habla conmigo para yo dar mis observaciones de cómo le va a funcionar el medicamento, se me hace muy difícil. O sea, me siento en desventaja porque ella no recibe de mí los detalles que necesita como mamá que está observando los efectos secundarios.
So Maria says that when her son goes for treatment, or they're going to talk about medication, she would like to share as the parent her observations of how the medicine is working or not working, and she doesn't feel like the doctor is hearing her.
Por la barrera del idioma específicamente, me siento como en desventaja porque el nene le explica lo que él siente, pero es importante también que la pediatra sepa las observaciones que estoy teniendo con el medicamento o efectos secundarios para mi hijo. Ella sugiere que
because
debo
of the
cambiar
disadvantage of the language. So mom speaks Spanish, her son speaks English. So he's sharing, you know, because he can in the English language. And then when she's trying to say what her concerns are, she doesn't feel like the doctor, and she would like to know, what do you recommend?
So I would recommend doing some sort of objective measure that you can share with them. So like the Vanderbilt rating scales, we have both initial ones, but also follow-up ones that talk about symptoms of inattention, symptoms of impulsivity, oppositionality, how someone's functioning, whether they're having side effects, and they come in both English and Spanish. So I would recommend doing one in Spanish and speaking to the office before his next appointment and say that you would like to be able to share that input, and you can do it that way because the rating scales, the numbers are the same in both English and Spanish. So even a clinician that doesn't speak Spanish can look at it quickly and say, wow, mom does not think this is working, or mom thinks these are problems. And I think any clinician we all have to take information from multiple sources. And sometimes these kids with ADHD don't always have very much self perception or perspective on themselves, and so I think that most people would care about that. Just like we care about teachers' opinions, we also care about parents' opinions as well. So that's what I would recommend, and those are all downloadable, free in the public domain. Vanderbilt rating scales.
Is there anyone else that has a question? All right then. So thank you for joining us. We're actually at 10:49, so I appreciate Dr. Ellison's willingness to stay longer. Oh, I just see someone posted something really quickly. I also have concerns more for CPAC. Okay, with my son, it addresses his dyslexia, but very little relating to ADHD. I'm furious that if this is how he has been functioning in the classroom, that I was notified at his triennial that he is not functioning and trying to assist him more with the ADHD. I have his transition meeting next week and we'll try to bring this up. I spoke to his teacher and para and they didn't say too much.
Okay. So Kia, just make sure that you, and it's fine to share my email address, and thank you for inviting me to speak.
Absolutely. Thank you so much. Everyone,
Welcome.
thank you so much. Have a great day. And today at 3 o'clock, we have a parent support call. So please consider joining us. And we actually have one last message from Andrew saying thank you. So,
Okay.
bye,
Thanks. Bye-bye.
everybody. Have a good one.